first presentation is Dr. Marcus Shams, and this is treatment of intractable hiccups using homeopathic phosphorus. A case report, Dr. Shams.
Who here has had a hiccup before? Most of you guys, right? It's a pretty common thing to have. If you ever wondered what's actually occurring, you have your diaphragm, which sits right here. It's what contracts to allow your lungs to expand, so to breathe in. So you just get this involuntary spasm that occurs there. It just spasms, and then your epiglottis, which sits right at the top of your trachea, just slams shut, and that causes a hiccup. Does anyone know how they named hiccups? Like, why is it called a hiccup? Anybody? It's the sound you make. So when you have a hiccup, it goes hiccup. So that's where that came from. Yeah, that's my first joke of the night. So starting out, they generally last like a few hours to up to 2 days. You can have a persistent hiccup, which lasts 2 days up to 1 month. Now, 1 month is quite a long time to have a hiccup, but that falls really short of what this person was experiencing. So intractable hiccups, which is what we're talking about today, that's when your hiccups go beyond a month. So this is, you've already experienced, well beyond 30 days of having hiccups. They persist despite medical interventions, meaning that whatever the physician tries, it just doesn't seem to improve. And the patient that ended up coming to us was in this state where they've had it for quite a long time. It's usually, at this point, is due to some condition. Something's going on underneath, maybe pneumonia, uremia, alcoholism. You can have disorders in your stomach or anywhere in the GI tract that can relate to this, or you can have a tumor or a surgical error along one of the nerves or near the muscle itself that causes this. So the history of this patient is a 56-year-old female who came in. She had 13 months prior, just sudden onset of very severe hiccups, just came out of nowhere. She underwent a very extensive medical workup before she ever came to us, which included brain EEG, so they looked at the electrical currents in the brain, MRI, chest, neck, abdominal CT. They did x-rays on her. They looked at her heart. They looked at her entire GI tract. And essentially, the only thing they found was 4-millimeter brain aneurysm at the base of the skull. And she also had decreased activity in the left lobe of her brain, suggestive of seizure activities. Now, looking at the neurologist's report, he seemed to have pointed that the seizure activity is most likely what was causing this person to have hiccups. So she came in 13 months after these all set in, and she tried a number of different things. So I broke down the meds she tried into ineffective and sort of effective. So ineffective, we have ADHD medication. We have a antipsychotic med used to treat schizophrenia, as well as a muscle relaxant. When it comes to effective remedies, they tried, the first one there is a GERD medication, which for the high school students over here, we all had pizza tonight, right? So when you get older, when you eat pizza, it causes a lot of burning lava sensation in your stomach. This medication is used for that. And finally, the last medication that was tried was an actual anticonvulsant, meaning that it lowers seizure activities in the brain. And so those two effective ones, they only provided a week to 2 weeks of mild relief for what she had going on. And by the time she came in, she was just on antidepressants. She wasn't on any medications. So presenting symptoms, what she came in with. She came in with about 1,200 hiccups per hour. That's about 20 per minute. And when you're sitting there in the room, she's in distress. It's just constant hiccups, constantly. She had chest pain, throat pain, difficulty falling asleep because of this, the hiccups. But what was interesting is that the hiccups went away once she fell asleep. So, interesting. So what's homeopathy? Homeopathy is what we used to treat this patient. We use it as a monotherapy. Essentially what it is, to really boil it down to something simple, it's a nanodilution, so very small amount of a naturally occurring substance that you give to a patient that stimulates their body's ability to heal itself. It works on the principle of like cures like, meaning that in a healthy person, a large quantity of this natural substance would cause these symptoms or the symptoms of a disease. So if you give an extremely small amount in a person that has a disease or has the symptoms, it can return them to health. It was developed in the 18th century by Samuel Hahnemann in modern-day Germany, and it's very individualized, meaning that there's a whole case taking, you listen to the patient, you try and learn what's going on exactly, and then you can find a homeopathic medicine that kind of matches those symptoms. So we took her case and ended up that homeopathic phosphorus was what matched her most similarly. And we administered it, or she administered herself at home daily. And the goals of treatment was pretty obvious. Let's reduce the hiccups she was experiencing, as well as all the additional accompanying symptoms she had. We tried to do follow-ups every 6 weeks. So this graph, as you can see, we have the anticonvulsant, which allowed her to go from 1,200, down to about 1,100 hiccups per hour. So very small improvement. And what I ended up seeing is that she was still on the medication when it went back to baseline, meaning that the body somehow compensated in the brain away from it, and she just was the same way before. Now, as you can see, when you get to the end, right before the drop-off, I feel like I'm favoring these guys over here. That drop-off, that's when we started the homeopathic remedy, and we saw a very mild improvement, let's say that. This huge drop, almost down to zero, almost zero. To zoom in a little bit closer on that, she had about 10, so 10 per hour, and that was on phosphorus 6C, which is just the remedy potency. And she was doing okay, started to plateau a little bit, meaning she wasn't improving anymore. We switched her to the next highest potency, which she saw a bit of an improvement again, and that was just a single dose. Plateaued again, and then we got her down to, I think it was like 0.16 per hour was the closest we came, and it did start to come back a little bit, and we had to play around with different remedies. But overall, what this case shows is that using homeopathic medicine and classical homeopathy in giving it to the patient, that you can treat drastically a condition that was untreatable up to that point, where we tried all the pharmacological agents. They went to multiple specialists. They tried everything. And 13 months after it started, to give a remedy and see improvement like this was quite substantial. Now, we're unable to completely cure the patient of her hiccups. She still had a few, but I think this is overall a huge improvement in her quality of life. Anyone have any questions? Yes, ma'am. How's she doing now? I mean, I haven't followed up with her. Yeah. I know that she saw a moderate return to some of the symptoms. It never went up to as high as she had before. And they were adjusting her remedies a few times. And I don't think it went above 40 per hour. And she then wanted to try CBD. So she went to another practitioner to get it because she couldn't get it here, to see how that would improve. And I haven't seen her back yet. Okay. Any more questions? Yes, ma'am. With phosphorus. So hiccups there is a rubric that shows that phosphorus can cause hiccups in high quantity in the materia medica, as well as the chest pain she was presenting with was very specific for how phosphorus presents usually. And there's some other, as far as, I'm trying to remember the other symptoms so long ago that's happened. Yeah, yes. And she was also better during sleep, which is one thing. Any more questions? Yes, sir. That's a really good question. Did the patient try any physical medicine? Of all the records I got from everyone, that very extensive workup, there was never any physical medicine in there. Although it would be interesting because, the phrenic nerve, vagus nerve, it all passes through. And, there was a C2, C3, and C4, I believe. But yeah, she didn't try it. Or at least we didn't have the records, and we got pretty extensive records. Yep. Yeah, the spontaneous remission question. So to me, 13 months of time had passed since she spontaneously developed these symptoms. We tried, or the neurologist tried, multiple different routes pharmacologically. And it just happened that in the 2 months that she started the phosphorus 6C, that they saw that huge improvement. I mean, there's always the chance that you can spontaneously recover from something, but I think in this case that timing, like 13 months, and it's interesting that it happened at that time. Any other questions? Yes, sir. So when they did the EEG, they found that the left lobe of the brain had diminished activity. And in reading the neurologist's report, he just said that that's probably what was causing it, and he didn't really put much emphasis into it. They just kind of go straight to treatment, and that's where they ended it. I mean, he didn't write that much about it, but it just said it's most likely due to a seizure. Okay? I think that might be time, right? Okay. Thank you guys so much. Oh. Thank you.
Okay, our next presenter is Dr. Taylor Steen, who is going to, so long. Thank you, bye. The second pizza delivery is here. No, I'm just kidding, I'm just kidding. All right. Dr. Steen, while she's getting mic'd up, is completing her first year as a resident at SCNM. Will be continuing the second year with an emphasis on pediatrics. And her case presentation is a resolution of headaches associated with idiopathic intracranial hypertension using homeopathic guanoinum. A case report.
Good evening, everyone. Can everyone hear me? Okay. So as they said, I'm going to be talking about the resolution of headaches associated with idiopathic intracranial hypertension using homeopathic guanoinum. So idiopathic intracranial hypertension, also known as IIH, is a condition characterized by increased pressure within the spaces that surround the brain and the spinal cord. While the condition was once known as benign intracranial hypertension, to distinguish it from intracranial hypertension associated with neoplastic malignancies, it is now known that the condition is not so benign. Many patients suffer from severe intractable headaches and even have a risk of vision changes and temporary blindness. The annual incidence ranges from 1 to 2 per 100,000 people and predominantly affects obese women of childbearing age ranging from 15 to 45 years old. So with the incidence of obesity rising in the US and around the world, the incidence of IIH is also on the rise. Compared to secondary intracranial hypertension, which is caused from a disease of, or another disease, idiopathic intracranial hypertension is a disorder of unknown etiology. So in order to make this diagnosis, you need a few things. You need certain clinical symptoms, which we'll discuss on the next slide, increased intracranial pressure with normal cerebrospinal fluid composition, and no other cause of increased pressure on neuroimaging. So the signs and symptoms vary between patients that suffer from IIH, but the common symptom is headaches. Headaches are not specific to IIH, but many patients state that they're extremely severe. You can also have associated nausea and vomiting with these headaches. Another common symptom is visual changes. These can include blurry vision, double vision, poor peripheral vision, or even temporary or permanent blindness. Some patients also get tinnitus and neck or back pain. And the hallmark sign of IIH is papilledema, which is typically found on examination of the eye, and it's the swelling of the optic disc. So IIH conventionally is typically treated with pharmaceutical drugs. The first-line treatment is acetazolamide, which is a diuretic, which has been shown to help decrease the pressure within the brain. Other pharmacologic interventions include headache prophylaxis medication, since that's the main symptom that most patients experience. And for the prognosis, there's no large prospective studies that describe the natural history of the condition. Many patients might have it for months to years. While medications can help kind of gradually improve their symptoms, there's not always recovery. So the patient that presented to us, she was 18 years old. She was a female. She came to us with severe headaches after being diagnosed with idiopathic intracranial hypertension. She was diagnosed approximately 6 months before her first visit here and had several trips to the ER for a migraine with no relief. So then she seeked out a neurologist and had many testing done. She had an MRI and an intracranial venogram, which were both normal. and she had a lumbar puncture, which showed increased pressure, diagnosing her with idiopathic intracranial hypertension. They weren't able to find a cause of it. So upon intake, she was experiencing severe daily frontal headaches for 2 weeks, and prior to that, she was experiencing them every other day. She rated them about an 8 to 10 on the pain scale, so 0 being the least amount of pain, 10 being the most amount of pain, so she was having pretty severe headaches. The treatments that she had tried prior to seeing us include acetazolamide, which is the diuretic, gabapentin, and amitriptyline, which are both nerve pain medications, and they were thought to help reduce her headaches, but she had no change in her symptoms when starting these medications. So we took an in-depth homeopathic intake, and based on her symptoms, prescribed glenoinum 30C, and she took 3 pellets once a day. The remedy was prescribed based on the following symptoms. So she had a throbbing headache, irritability with her headache, her head felt enormously large, she had a heavy head but could not lie on the pillow. Her headache was worse with stooping and lying down, and it increased and decreased every day with the sun. So the goal of our treatment was to decrease the frequency and severity of her headaches to give her some relief. So as you can see on this first graph demonstrates her frequency of headaches. So treatment was started at day 0. So before coming to us, she had a headache almost daily. Once we initiated treatment at day 0, her first follow-up was about 1 month later, and she reported 5 headaches from her previous visit. So the first day that she took the remedy, she was actually headache-free for the first time in 2 weeks. At her second follow-up, which was about another month later, she reported 6 headaches from the prior visit. And then at day 110, she was headache-free. This next graph demonstrates the severity of her headaches rated by the patient. So again, the scale was 0 to 10, 0 being no pain, 10 being the most pain. Before coming to see us, she rated them an 8 out of 10. And then at her first follow-up, a 7 out of 10, and as you can see, it slowly goes down until she was headache-free at day 110. So in conclusion, this case demonstrates a successful resolution of headaches associated with idiopathic intracranial hypertension using homeopathic glenoinum. And I have spoke to the patient recently and got an update. She's no longer taking the homeopathic remedy, and she is still headache-free. She was also able to discontinue some of her pharmaceutical medications. And any questions? Yes. I would have to look back at her records. When going through them, I don't remember them giving a certain level. They had just diagnosed her with it, but I can get back to you if you want to. Yeah. Yes.
Have they assessed the hypertension to see if the pressure is decreased, or if this is specific?
She has not had a repeat lumbar puncture that I know of, but she is symptom-free. No papilledema anymore either. So. Another question? No? Yes. Oh, yeah. Anything else? All right, thank you.
I have 3 questions.
Oh, yes.
But you should applaud first, just in case. So question number 1, it's kind of an odd terminology because you think it's increased intracranial pressure as in CSF, because they would be measuring the pressure through the lumbar puncture.
Mm-hmm.
And so for hypertension, I would think that it would be vascular. Is there a vascular component to it also?
So with the intracranial hypertension, they can either have an overload of CSF or trouble draining it.
So then probably not.
Yeah.
'Cause it's interesting because there's a type of dementia called multi-infarct dementia, which you would think that when you were talking about it not being benign, that that is something that can lead to dementia for people with hypertension, but more vascular. And then the last question, which is for the audience, for students only, which is, what is glenoinum? So I'll give you a clue. It was first introduced as a homeopathic drug in the 1850s, and it was afterwards it was introduced as a very common medication that if you've taken ACLS, how many of our students have already taken ACLS? Raise your hands. No, and so if you, well, it's nitroglycerin. Yeah, nitroglycerin. Okay, I'm done.
Thank you.
Our next presentation is by Dr. Berlin Wright, who will give us a presentation on a case study of a patient with chronic Manraja using homeopathy.
All right, can you guys hear me? Okay, great. So yeah, I'll be talking about the treatment of Manraja with homeopathy tonight. So what is Manraja? Manraja is defined as menstruation with excessive flow, but at regular cycles, and it's for 7 or more days with bleeding that can cause bleeding of more than 80 milliliters for the whole cycle. So just to give you a little perspective, normal blood loss for a female is less than 80 milliliters, and average is about 40 to 50 milliliters per cycle. So there's no labs to diagnose Manraja. It is a clinical diagnosis, and common etiologies include fibroids, endometriosis, polyps, bleeding disorders, cancer, and hormonal imbalances, and it can lead to anemia, dysmenorrhea, and poor quality of life. So we're going to talk a little bit about conventional treatment for Manraja. First line is usually medications such as NSAIDs, Listida, and hormonal either birth control pills or IUDs. And if those don't treat the Manraja appropriately, then they go to second line, which is usually surgical, so either ablation or hysterectomy, and that's about the extent of conventional treatments. So our case is a 45-year-old female that presented to clinic with heavy menstrual cycles for over 13 years. She had also had a history of anemia and hair loss. So when she came in, her cycles were about 6 to 7 days, sometimes a little bit longer, up to 9 to 10 days. And she had to change a Super Plus pad hourly on her heaviest day. She also experienced symptoms of flooding, leaking, clotting, cramping, fatigue, and bloating, and other PMS symptoms. She was previously diagnosed with elevated reverse T3, iron deficiency anemia, and fibroids, which were likely either causing or contributing to her Manraja. So before she came to see us, she'd also seen multiple different physicians and gynecologists, and she tried birth control pills, other medications, and supplements, and some of them worked short-term, but none of them were really doing it for her. So they also recommended that she get an ablation or a hysterectomy, but she declined because she just didn't want to go that far. When she came in, she was taking liothyronine, 5 micrograms twice a day, DIM, 1 capsule twice a day, slow flow, 3 capsules twice a day during her menses, and once a day the rest of the month. And she was also taking an iron supplement of unknown dose, 1 capsule 3 times a day. So what did we do for her? We did homeopathy as well as the last 2 cases, and we did intake that was 3 weeks long. And so we didn't actually prescribe the homeopathy until her 3rd visit. So before that was done, we only made minor adjustments to her treatment. So we increased the dose of the slow flow to 3 to 4 capsules every 3 to 4 hours during her menstrual cycle. And then we also recommended Castor Oil Packs 3 times a week for 30 minutes. We also did a couple labs just to see if there's anything else that could be causing or contributing to her Manraja, and we didn't find anything. So on the 3rd week after we studied her case, we prescribed Sabina 30C, and this was chosen based on the symptoms of bright red menstrual bleeding with dark clotting, intermenstrual bleeding, dysmenorrhea, profuse menses, and being sensitive to odors. And then throughout her treatment, we tracked her symptoms, which included flooding, clotting, the color of the blood, how long her cycle was, irritability, headaches, other PMS symptoms, as well as her quality of life. So this first graph demonstrates the length of her menstrual cycle over the treatment. So this first point right here, month 0, is when she first came to see us. And at that point, that's when we just mildly adjusted her supplements. And so, as you can see, there was not really any change in her length of her cycle, and as you'll see in her other symptoms as well, up to that point. And then at about the 1 month, oh no. Am I back? Yes? Okay. And so then at the 1 month mark is when we prescribed the Sabina 30C. And as you can see, after that, the length of her cycle continued to decrease through her treatment. She did start to plateau a little bit after a couple months, so that's when we increased the potency to 200C. So this next graph shows blood loss on her heaviest day. So when she came in, she was at about 120 milliliters of blood loss on her heaviest day. And just to put that in perspective, if you remember, normal cycle is anything less than 80 milliliters of blood loss over the whole cycle. So she was losing 120 milliliters just in 1 day. And then with the initiation of the homeopathy, she started to decrease. And after a few months of treatment, she was down to 40 milliliters of blood loss on the heaviest day. And another little fact about her is that, so as I mentioned, she had to change her Super Plus pad every hour on her heaviest day at the beginning. And after a couple months of treatment, she was down to 4 per day on her heaviest day, and then continued down to about 3. And she also was able to start wearing tampons again, which she hadn't done in years because her symptoms were so severe. So this last graph is a subjective symptom severity. So the symptoms included cramping, bloating, irritability, clotting, flooding, and other PMS symptoms, as well as her quality of life. So when she came in, on a scale of 1 to 10, 10 being the worst symptoms, she ranked them at about an 8. So pretty severe. And then with the initiation of treatment, they started to decrease. And towards the end of the 5 months, she was down to rating them at about a 1 out of 10, which is a pretty significant decrease. And you can see more clearly in this graph that she started to plateau and regress a little bit with her symptoms, which is why we had increased the potency to the 200C. So in conclusion, this case demonstrates the effectiveness of homeopathic treatment, specifically Sabina, in chronic Manraja that was unresponsive to other treatments. And we do still see her, we follow up with her, and she's doing really well. Her symptoms are very minimal, and she's extremely happy because it was really ruling her life, and now she feels like she can just live her life and be happy. Any questions? Yeah. Uh-huh. It should, depending on the cause, it should, but it's pretty invasive, so a lot of patients prefer not to do that if they don't have to. Yeah. 45. Mm-hmm. Yeah, so flooding in a menstrual cycle is where like you have gushes of blood that it's so extreme that it can bleed through anything that you're wearing and cause a lot of distress. So it's just like a big gush of blood and will all release at once and is just like, really severe. Any other questions? Yeah. Mm-hmm. Yeah, so we increased the potency because she was plateauing a little bit and not responding as well anymore. And some of her symptoms started to come back, so we wanted to increase to basically re-stimulate her body. Everything pretty much remained the same. She might have stopped the castor oil packs as frequently, but yeah, everything else remained the same. Yeah. It had been for about 13 years, so it was actually after she had children, and she was on birth control pills for a while and then stopped them, and then that's when it really started. Yeah. She is taking it. She's no longer on 200C. She's on a higher potency now, and she takes it not every day, a little bit differently, but she is still taking it. So recently, we have started to decrease her doses of stuff, and she doesn't need it, like all the crutches as much. She still takes it as needed, but a lot less, a smaller dose. Yeah. Mm-hmm. Mm-hmm. No. Mm-mm. I don't believe they carry Sabina at Sprouts, do they? No, we can get it. Oh, yeah. We can get it. Yeah, you can get it here without a prescription because it's homeopathy, but at like grocery stores, they don't usually carry that one. Mm-hmm. It doesn't necessarily mean that. We don't have any follow-up imaging, so it's hard to say if that, is a factor in it. But it could have just, helped her body heal in a way to decrease bleeding. All right. Anything else? Okay.
Thank you. Okay, Act 1 was homeopathy, and now we're moving on. Dr. Madeline Schafferman is going to present treatment of estrogen dominance with dietary intervention. Dr. Schafferman.
Thanks. Hello. Sorry, I'm not Britney Spears by any means. So I'm going to be talking about estrogen dominance and a really simple intervention. So estrogen dominance is not a well-defined term, so for the purposes of this discussion, I'm going to be describing it as levels of estradiol that are high in circulation or, levels of estradiol relatively high compared to progesterone. There are a variety of estrogen-driven conditions. This is a list of a few: endometriosis, fibroids, breast cysts, ovarian cysts, PMS, and you can read the rest. I'm going to dive a little bit deeper into endometriosis because that's what our patient presented with. So per UpToDate, endometriosis is an estrogen-dependent benign inflammatory condition that affects women throughout their life. Endometriosis, for the non-medical people in the room, is when their endometrial tissue that's typically found within the uterine cavity is found elsewhere in the body. So when we have our menses, instead of all of the tissue being able to exit the body the way that it should, the tissue responds the same way and can cause a series of symptoms. So symptoms commonly associated are dysmenorrhea, painful periods, Manraja, excessive menstrual flow, dyspareunia, pain with intercourse, and infertility. Our patient presented to us as a 25-year-old female. She was diagnosed with endometriosis via laparoscopy at age 19. She has a history of ovarian cyst ruptures that were confirmed on ultrasound. She had a 4-year history of hormonal contraceptive use with a variety of side effects, so she decided that was not the best fit for her. She presented us with dysmenorrhea, Manraja, fatigue, and acne. She was currently following a vegan diet at the time she presented, and she was hopeful to continue that throughout the time that we were working with her. We decided it would be best to establish a baseline, so we decided to run female hormone panel, and we ran it on day 19, which is within the luteal phase of the menstrual cycle, and these are our results. So you'll see on the screen here, the normal is a very approximate normal. Everybody of the medical side knows that that's not really a set thing for any one person, but her results are pretty significant. So estrone and estradiol are two of the forms of estrogen within our body, and you can see they're vastly elevated. Progesterone is very suppressed in comparison to an approximate normal here, and so per our criteria and our definition we're using, she definitely meets estrogen dominance. On this side, these are the signaling hormones from the brain down to the ovaries, and you'll see that they're highly elevated. They're typically found in an elevated fashion such as this when a patient is menopausal or postmenopausal. So at this point, we may have some concern for infertility in this patient. So what did we do? So these are the 4 types of interventions that we implemented. So the first portion of what we did was we had the patient complete far-infrared sauna. Far-infrared sauna is used to deeply penetrate tissues and mobilize toxins. Ideally, the patient would exit the sauna approximately every 10 to 15 minutes and would rinse with a cold shower. Our patient did far-infrared sauna treatments at home, so instead of using a shower every 10 minutes, she did cold mitten friction and then ended the about 40 minutes that she did the far-infrared sauna with a cold shower. We also implemented castor oil packs, as previously discussed in Dr. Wright's presentation. We had her apply the castor oil over the liver, the abdomen, and the uterus when she was not on her menstrual cycle. So castor oil is derived from a plant, and it's known to be anti-inflammatory and also support the liver, aid in lymphatic flow, and improve digestion. These are some of the dietary changes that we implemented. All of these are found outlined in Dr. Marchese's 8 Weeks to Women's Wellness. So some of the goals here were to excrete excess estrogens. So we increased her DIM-containing vegetables. We had her increase her fiber, along with increasing liver-loving foods and some other things to help promote detoxification. And we ensured that the only produce she was eating was organic. We also implemented some supplemental nutrients specific to her concerns that she presented with. One of those concerns was fatigue. So we had her start an adrenal glandular that had a herbal blend of adaptogens to help support the adrenals. We also started her on a protein powder that also contained fiber and multiple nutrients to further support the detoxification process, and a supplement that contained DIM, which is specific to excreting excess estrogens. And these are the specifics on those supplements. The fourth and final portion of our intervention was avoidance. So we educated our patient on things that can impact her endocrine system, such as plastics. Some of them are known endocrine disruptors. We had her pay attention to where she was sourcing her foods. We directed her attention to the Environmental Working Group, which produces a Clean 15 and Dirty Dozen list every year to help kind of guide the way that we're choosing and selecting our foods. We also helped her source water and ways to purify her air so that she wasn't going to be affected in that way as well. And then we also discussed household cleaners and items that can impact her negatively, along with body and beauty products. All of these things she implemented strictly over 9 weeks. And at that point, it was day 19 of her menstrual cycle again, so we drew another set of labs. So, as you can see here, we had some really significant outcomes. So estrone and estradiol fell dramatically, which we anticipated because we were specifically targeting excreting our excess estrogens. But we did not necessarily anticipate the rise in progesterone and the decrease of the signaling hormones. So, like the majority of our lovely patients, she was really happy with her results, so she stopped everything. So she was curious to see where she was. It was about a year later, and she came back to us, and we drew, again, her labs on day 20 of her menstrual cycle, and these are the results. So, as you can see, not huge changes, definitely nothing near where she started. So we're really pleased with that outcome. We also wanted to evaluate her clinically. So we use the symptom severity scale, 10 being the worst, 0 being the best. And throughout her treatment of the 9 weeks, we can see that the dysmenorrhea, Manraja, and acne all improved dramatically, while energy increased dramatically. So from this case, we can see that we can successfully treat estrogen dominance with a whole person naturopathic approach. We can see that it also demonstrates that a fairly simple intervention over a relatively short time frame can be really substantial. It's completely changed this patient's quality of life, so that was really great. And it also demonstrates that the body was able to regain hormonal balance. We really only targeted decreasing excess estrogens, but the body was also able to increase progesterone while also decreasing those signaling hormones. There we go. Any questions? Yeah. She did continue the avoidance portion, but she discontinued all the supplements. She no longer was vegan. She just kind of lived her best life. And she definitely discontinued the hydrotherapy. She was pumped to get rid of that. Go ahead. She was doing saunas daily. Why did she use castor oil? Why didn't she use castor oil during menstruation? So she had Manraja, which is the excessive menstrual flow, and applying heat over the uterus can increase flow. And because castor oil packs include that heat element, we wanted to discontinue any potential of increasing that. Anybody else? If someone came to me and said, I'm willing to do one thing, what do you want me to do? I would probably have them do the dietary changes. I think that would be really substantial. There's a lot of that blend or that list of suggestions that we had in Dr. Marchese's book that we outlined really tackle everything. So I think it would take a longer period of time, but I think it would be a pretty substantial outcome.
Do you think the microbiome had anything to do with your case?
For sure. The microbiome impacts everything. So I definitely think that was a portion of it. And I think by changing diet, we were able to impact that in a positive fashion. Anybody else?
So some of your treatments really it looked like targeted liver function. The castor oil packs, a lot of the dietary interventions. So could you speak a little bit about your underlying assumption or working diagnosis about what was the pathophysiology underlying the endometriosis that led you to treat it in that way?
So we know endometriosis is an estrogen-driven condition. I have the belief that most estrogen-driven conditions are because we can't functionally clear our estrogens. So I think by impacting the liver and really giving it what it needs to clear things and process properly, we're able to have that substantial outcome. And so that's why the majority of what we, or a lot of what we did impacted and really focused on liver function. Thank you.
Our next presenter is Dr. Linnea Felton, and her case presentation is the treatment of alcoholic hepatosteatosis with acupuncture and Chinese herbal tea pills. Dr. Felton.
Hey crew, how we doing? Hanging in there? Getting kind of long? I know. All right. Well, so I'd like to tell you guys about a really fantastic patient that we had that we treated with acupuncture for more of an acute presentation than the other cases that we've chatted about tonight. She had alcoholic hepatosteatosis, which I'll get into a little bit, that we treated with acupuncture and Chinese tea pills. So going into a little bit about what acupuncture is, for those of you who aren't familiar, it was founded around 500 BC in ancient China basically based off of the theory that we have two opposing energies within our body, yin and yang, which you may have heard of before, kind of with that traditional symbol that we see. What happens is that yin and yang needs to be in harmony for us to not have any disease conditions. And qi is the energy that helps move those things along in our body to prevent disease. When any of those things are out of balance, that's when disease and symptoms occur. Diagnosis in Chinese medicine is based off of a couple different things that is a little bit different from what we see in Western medicine. So diagnosis is certainly based off of the symptoms that they have. That tells us a lot about kind of the organs that are affected, but it's also based off of what the tongue looks like and what the pulses feel like, because those also correspond to kind of what's happening in the disease state in their body. When we do acupuncture, there are points pretty much all along every single surface of your skin that run in lines called meridians, and our goal is to help remove the stagnation in those points that's causing disease. So defining a little bit about what the condition is that the patient had, it's called alcoholic hepatocytosis, and there's a couple different phases. She was in the first phase that is essentially called fatty liver, and the etiology or the cause behind this is binge drinking. This differs between genders, so women it's typically around 4 drinks, and if you can kind of see here on the side, this is really the visual definition of what these drinks quantity are. Women, it's around 4 drinks. Men, it's around 5. And the definition of the diagnosis is drinking that amount in a 2-hour period, 1 day in the past month. What happens essentially when people are drinking alcohol is the fat metabolism in our body changes. So we'll start to notice increased breakdown of fat or increased lipolysis. There's a mitochondrial change as well with how fatty acids are processed, and also an increase in triglyceride production. The effects of this can range depending on kind of how long people are binge drinking for and the treatments that are integrated, but initially, we have fatty liver that with continued drinking can result in chronic hepatitis with fibrosis or hardening, and then the final end stage, which is cirrhosis, which is irreversible liver damage. Symptom picture can vary between patients, but typically we see them coming in with nausea, vomiting, anorexia or loss of appetite, fatigue. If it's really advanced, we'll see jaundice or that yellowing of the skin. Laboratory tests that will run with the blood, GGT is typically we'll see elevated if people are abusing alcohol. ALT and AST are both markers of liver functioning, ALT being more specific towards liver damage. Imaging will typically do an abdominal ultrasound, abdominal CT, which is a cross-sectional study. In order to diagnose this, we do need a biopsy, but guidelines are stating that the cross-sectional study or the CT is acceptable. As you can see kind of with this little infographic here, that on the left side is what fatty liver can look like, which is dramatically different from what a healthy liver looks like. With the deposition of fat cells in the liver can cause liver to grow up to 3 times the size of normal, which is pretty significant. Traditional treatment of this condition is abstinence of at least 6 months of alcohol, typically kind of for the rest of their life, just because of the damage that they incurred for their liver. Some pharmaceutical interventions are primarily aimed at both inflammation management as well as alcohol craving control, and you can see a couple of them listed up there. Liver transplant, alcoholic liver disease is the #1 reason why people in North America receive liver transplants. And in addition to being really expensive, there's also a really high rejection rate and also a really high infection rate. So it's something that, this is definitely needed, that we need to figure out kind of how to manage it so that we don't get people to that phase. So to introduce you to our patient tonight, she was a 66-year-old Caucasian female who was diagnosed with alcoholic liver disease on both abdominal ultrasound and laboratory testing. She had a significant social history of drinking 2 glasses of wine a night. And from this, prior to coming to us, she had a 4-month history of suffering from intractable vomiting, nausea, and abdominal cramping that eventually led to a 20-pound weight loss and really significant fatigue. They tried to treat her with multiple hospital visits with ondansetron or Zofran, which is an antiemetic or anti-vomiting medication, and dicyclovirine for the abdominal cramping, which is an antispasm medication. she tried these for each time that she was admitted to the hospital. They provided no relief, so she totally discontinued. Interesting with this patient, she had a 45-year history of constipation that was incredibly exacerbated by stress. She presented to us after a recent relationship change and a loss of a family pet, in addition to these crazy symptoms that she was having, so she was under really significant stress. That constipation led to laxative dependence. She was not able to have a bowel movement without taking Metamucil, which is a well-known over-the-counter laxative. And without that Metamucil, she would have a bowel movement every 3 days, which was pretty impactful for her life. Oops. So what we ended up doing based on her symptoms, like I said, with the pulse and the tongue diagnosis, her pulse was pretty wiry and slippery, which indicates a liver condition as well as some dampness that's in her body. And her tongue looked pretty puffy with some scalloping, which again kind of supports in Chinese medicine that dampness that's in there. With all of those components together, we diagnosed her with liver and stomach disharmony with spleen sheet deficiency and applied these points that are listed on the screen, both in writing on that side and also as an infographic on the right side there for a visual. We also incorporated some TCM herbals, which the first one here at the top, 6 Gentlemen Plus, was specifically indicated for her diagnosis to help with some of the symptom management. The second, Mazi Renwan, was indicated specifically for her constipation. Both of these herbals were given 10 T-pills 3 times a day, which you might think 60 pills in one day seems like a whole heck of a lot. Not sure if I want to sign up for this, but I will let you know that these T-pills are around the size of the tip of your pinky or about the size of a BB gun pellet, so pretty tiny. Most of them have a slight herbal taste to them, and they're pretty easy to get down. We have some pretty good compliance with this. The purpose of adding in the herbals was kind of to extend the effect of the acupuncture treatment beyond when she was in our office, but also kind of when she was at home. What we started to notice was a pretty dramatic improvement in all of her symptoms across the board. So as we can see here, the treatment was applied week 1 here. And with the first follow-up, or that week 2 visit, we started to notice, hey, nausea was pretty much cut in half. She was no longer really noticing this as part of her major concern, and by the subsequent follow-ups, she really rated it as a pretty negligible part of her symptom picture. Vomiting, even more of a dramatic improvement. As you'll remember, she had intractable vomiting every single day that led to that major weight loss. With that very first follow-up that we see again at week 2, really significant improvement. Towards week 3 and onward, she had no more vomiting, excuse me. Constipation, we also saw an improvement, primarily due to the addition of that Mazi Renwan T-pill. We'll notice that kind of with this dramatic drop here, she was taking those 10 pills 3 times a day, as you'll remember. But then she started having 5 bowel movements a day, which was a dramatic change from what she was using before, not using Metamucil at that point. So we instructed her to half her dose to 5 pills 3 times a day. With her second follow-up, we instructed her to use as needed, and she has been able to have a bowel movement by herself with no medication or T-pills since then. Fatigue was kind of secondary to her symptom picture and her disease process. Really major improvement with this as well. Towards at the week 6 visit, she had no more concerns of fatigue, and this was not part of her symptom picture anymore. Anorexia, or that poor appetite, again, we see a really major decrease in that as well. To, again, when we see week 6, anorexia was no longer a concern of hers. Anxiety was a pretty major part of her symptom picture, and we see that dramatic improvement, or that decrease in anxiety, after that very first follow-up, and she kind of maintained that 2 out of 10, 10 being the most severe. So we can see that by utilizing Chinese herbals and acupuncture in conjunction, with just this, it was a 30-minute treatment 1 time a week for 6 weeks. We really got a great handle on her symptoms, and it was no longer a concern of hers. I have talked to her since then. She has since had an acute exacerbation of gallbladder cholestasis kind of type thing. We don't have any labs for her. They're pending as of right now to kind of view the difference between pre-treatment and post-treatment. So looking forward to those, but she is, aside from that acute gallbladder condition, is feeling much better and is really grateful for our help. Any questions? She did, yeah. Prior to coming in to us, she was instructed by the emergency department to totally discontinue, and she had maintained that abstinence since. Any other questions? That's another thing that we're waiting on. It's kind of pending as of now, but we're interested to see those results as well. Yeah, correct. So we're just waiting on the abdominal ultrasound as well. Anything else? All right, thank you.
Okay, Dr. Ashley Milheiser will present a case describing a regression of disease in treatment-resistant advanced stage endometrial cancer with Viscum album. Case study. Dr. Milheiser.
Thanks. Okay. All right, I'm going to stand over here. Okay, so I'm going to be talking about a case, that's really loud, demonstrating the regression of disease in treatment-resistant advanced stage endometrial cancer with the use of Viscum album. So a little bit of background information about endometrial cancer. For those of you who aren't familiar with it, it's a cancer affecting the inner lining of the uterus. It is the most common type of gynecological cancer in the United States. If caught early, it has a pretty promising prognosis of a greater than 90% 5-year survival rate. And then, like other cancers, if it's caught later on, as it progresses, the prognosis significantly declines. So here's some of those numbers associated with that. Here's some information about how the diagnosis occurs. There are no specific blood tests related to diagnosing endometrial cancer, so both diagnosis and progression are made and monitored through biopsy and imaging. Some of the symptoms that a person might present with that would lead to the diagnosis of this cancer are most commonly bleeding in postmenopausal women. This is significantly more common in postmenopausal women. They may also have clear white vaginal discharge or abnormal cervical smears. And in the rare cases that it does occur in a premenopausal woman, they may present with irregular bleeding. They may have abdominal pain or weight loss if it's more advanced. And then this is a little bit about the staging of endometrial cancer. When a person's diagnosed, they're both staged and the tumor is graded. Stage 1, the cancer is confined within the uterus, and then subtypes A and B being determined by how much it extends into the myometrium, which is the muscular layer of the uterus. And then stage 2, it is now spread to the cervix, but is not extending beyond that. Stage 3, it's now gone beyond the cervix, but it's still confined within the pelvic area, and subtypes A to C2 being defined by whether it's spread to the vagina or as far as the periaortic lymph nodes. And then finally, stage 4, the cancer has metastasized to other organs, stage 4A being involved with either the rectum or the bladder, and stage 4B now may have distal organ involvement like the lungs. And then, as I mentioned, the tumors are also graded. The grading helps the physician determine how quickly this cancer might metastasize. So they're graded based on how much they look like healthy tissue. The more it looks like healthy tissue, the more it's considered well differentiated, the better the prognosis. So as the grading gets higher, the worse the prognosis. And then this is some information about how endometrial cancer is typically treated conventionally here in the United States per stage. Stage 1 involves the removal of the uterus and potentially the ovaries. Stage 2, we're now not only removing that area, but additional tissue that may be involved, such as the vagina or vaginal tissue or cervix, anything that might be involved. We're also assessing the lymph nodes, and this is where you first start to see the addition of radiation. And then with stage 3, not only are we doing a pretty significant surgery, if possible, but you're also adding in the chemo prior to the radiation. Stage 4 treatment can look pretty similar to stage 3, although because the prognosis is pretty poor, it may be a more palliative approach depending on the patient's desires. And then this is a little bit of background information about the particular treatment that was employed in this case study. Viscum album, many of you may be familiar with it. It's more commonly known as mistletoe. Helixer is a particular product that is an aqueous cold extraction of that. And oral consumption of this is actually poisonous, but it's been heavily evaluated for its safety and efficacy in relation to cancer treatment. And it's been shown to improve survival time, to decrease the symptoms both associated with the cancer and cancer treatments, and decrease recurrence, and then, of course, improving quality of life. Some of the actions that the extracts have that are particularly of interest and related to cancer is its ability to stimulate the immune system and the natural killer cells, and to decrease tumor migration and invasion by binding to the tumors and inhibiting protein synthesis. So, and then additionally, this treatment has already been being used in Europe for over 100 years now for a variety of different cancers, from breast cancer to renal cell carcinoma to pancreatic cancer to liver cancer. But what's particularly interesting about the case that I'm about to present to you is that there has yet to be any research published about its efficacy and use in relation to endometrial cancer specifically. So here's our case. It's a 78-year-old female with a history of chemo and radiation-resistant advanced stage endometrial cancer. She was first diagnosed in 2006 with stage 3B adenocarcinoma of the endometrium and a tumor grade of G3, so she was pretty far along. She initially had surgery to remove the uterus and also had chemo and radiation, which resulted in the remission of her disease. In 2014, she had remission and was now found to be in stage 3C, so a little bit more advanced than previously. She did a second round of treatment, and by the beginning of January 2015, she went back into remission. 4 months later, she had a follow-up CT, which demonstrated a second recurrence of the disease. At this time, she went through another round of treatment, and the response was not as good. She was no longer responding to the treatment. Her cancer was progressing despite ongoing treatment. So that's when she presented to the clinic in November of 2016, looking for more of a palliative care approach, because as I mentioned, it can both be used along with chemo, and it can also be used to just decrease the symptoms during the cancer, or as a standalone. She received a standard dose of the Helixer M product, and it's given subcutaneously into the abdomen where the sites rotated each time. She received 3 injections per week for 2 weeks and then would take the following week off, and that dosing schedule was kept throughout the remainder of her treatment. She did that treatment for 12 months. And this is some imaging that corresponds to the treatment. This was a PET CT scan that was taken prior to her beginning the Viscum album injections. And I know it's a little bit difficult to see, but this area here is one of the lesions of interest. And if you can see it, I did include the radiology report if it's hard for you to see or if you're not used to reading scans like these. But it does have a heterogeneous appearance here with a little bit of a focal abnormality in the center, which I'll get back to. But they not only note the presence of it on the report, but they also note the size of it here, and that it is ill-defined soft tissue that's suspicious for recurrence of the disease. So this was prior to her beginning treatment with us. And then 1 month after treatment, here's a comparison image, and I know it doesn't look like a huge difference, but again, this has only been 1 month. It may have a little bit of a decrease in size, but you can note that there is a difference in the texture and appearance. It's got a now more homogeneous appearance. And they even note that here on the radiology report that it's mildly less conspicuous, there's less radioactive uptake, and then that focal center that I was talking about appears to have subsided. So she's responding to the treatment already at 1 month. And then here we're looking at 4 months out. So again, this is the prior to treatment, 1 month after treatment, and now 4 months after treatment. And here you can definitely see that the lesion has decreased in size, and it's beginning to look more like the healthy surrounding tissue. And then they note here on the radiology report that it's resolved hypermetabolism, so it's beginning to behave like normal cells, and that this is suggestive of successfully treated disease, and that there are no definite new, or there's no new or progressive metastases. And I wasn't able to grab a slide from the radiology report that happened 11 months after treatment, but this is, or not the actual slide, but this is the report. And so here you can see that they note that there's no avid disease in the head, neck, chest, abdomen, pelvis, or musculoskeletal system, There's no adenopathy, and there's no avid malignancy. So there's no evidence of existing disease. And this patient has continued to follow up with her doctor, her OBGYN, as well as the doctors here in the clinic, and as recent as just a couple of months ago, and she still continues to have no evidence of existing disease, and I'm awaiting those records currently. So just a little bit of discussion on this. A reminder, she had completely discontinued all conventional treatment prior to beginning the Viscum album injections. And so we can assume that due to the injections alone is what we can accredit her remission to. And then this is also a little bit of a call to action piece because, as I mentioned, there's a lot of research out there on PubMed about how this is being treated in a bunch of different cancers out there. This is the first time we mentioned it with endometrial cancer. But here in the United States, a physician is only allowed to recommend the use of Viscum album as a cancer treatment if the person knows that it's an investigational drug and that they've completely failed all conventional alternatives. So with our patient, she was no longer responding to treatment and she was pretty far along. So that's why we're able to give it to her. Any questions? Oh, yes, sorry. I'm not sure. I'm going to defer to this question. Yes. Well, it definitely goes systemic. I don't know that you can really course the exact pathway of it, but this treatment can be applied in a couple different ways, subcutaneously, and then there is some cases where they'll actually inject it into the tumors if they're more superficial. So it's like under the skin. Well, yeah, your body absorbs that. Yeah. Any other questions? In the abdomen, so the site's rotated each time. Yeah, they're based depending on the person's age, weight, but this was a pretty standard dose. So would the patient need to take this with chemo? So in Europe, they're using it alongside chemotherapy, both for decreasing the side effects. Like I mentioned, it's been shown to help with insomnia, nausea, vomiting. You can also use it as a standalone, as we did here. Like I mentioned, in the United States, that has to be followed by a certain course. Like they have to already have tried conventional alternatives or failed conventional alternatives. But you can use both. This patient's no longer receiving this treatment. They stopped this in 2017, and they still are remaining disease-free today. I think I'm going to defer that question to Dr. Polson. She handles this a lot more than I do. Thank you.
Right. Well, there's been a little bit of a change in the name because we finally got a diagnosis for this patient, and it is the treatment of idiopathic late onset cerebellar ataxia, with the main emphasis being on biomodulator therapy. Idiopathic late onset cerebellar ataxia is mainly a cerebellar ataxia. That it's its main definition, and it's basically a stumbling and steady gait, poor coordination, but it also has these extracerebellar features, which are abnormal reflexes, sensory losses, sensory changes, cognitive impairment, involuntary movements, slowed speech, weakness, also all of these things listed up here. So the basic treatment goals for this condition are mostly supportive therapies. Physical therapy and occupational therapy are the biggest thing that they do because it's just gets them through the condition. We can also do symptomatic management to really just get them through. Other than that, there's really no treatment that has been set forth that has been productive. So on to our case. So our case was a 45-year-old female. She presented to the Roosevelt Health Clinic, best place ever. She presented there, and she had 11 years of progressive ataxia after giving birth to her youngest daughter. It was slow on onset, and then by the time we had seen her, she'd already gotten a CT, which was completely normal. We went ahead and ordered at the beginning of the year MRI, which was also completely normal. And we also ran the gamut of testing, and there was nothing came back positive. She was healthy as far as everybody understood. Her neurologist said she was healthy. There's nothing technically that we can diagnose her with. And she had no family history of a neurological disorder. So the symptoms that she experienced, she had ataxia, which is that abnormal gait that I was talking about. She also had hyperreflexia, hyporeflexia, muscle weakness, sensory changes, eye changes, memory loss, brain fog, all of the things listed here. So, what did we do? Our goal of treatment was to just improve muscle strength, coordination, and slow the progression of her symptoms. We didn't really have anything set out too great, too big for our goals. And then we decided that biomodulator would be our primary treatment modality. And we specifically used the solfeggio mode, which I'll get to that in a second. And we required that she had weekly treatments regularly. And then we also gave her supplements to help support the biomodulator. These supplements were just to support the neurons and help with everything that they were doing. They were regenerating, which you'll see here soon. So the biomodulator, it looks very similar to a TINS unit. For those of you that have seen it, it looks like a little box almost, but it's not a TINS unit. It's totally, totally different. It's a microcurrent machine. And what it does is it stimulates the body to release its own endorphins and neuropeptides and stimulates the release of ATP in the body. And what it does is it really just promotes regeneration in the body as a whole. And what we did, which is this picture right here, are the little pads that we use. She sat in a chair, very similar to the ones you guys are sitting in here. The big ones, these big pads, her feet went on, bare feet went on those guys. And then these guys they're like little rods that you can hold, very similar to this. And that is the electrodes. All 4 of those are electrodes that stimulated the microcurrent through. And the solfeggio mode is the exact mode that we used on Biomodulator. And what this is it's a very specific set of frequencies that are sinusoidal waveforms, and they are produced for 40 seconds, and they're cycled through this list right here. And what these frequencies are, they're thought to be stimulating the body's own energy centers and regenerating the body's own ability to heal. So we did this regularly. And then now on to the actual cool part. This is where we actually get some results. So just a reminder for everybody, these are reflexes. This is the reflex grading scale. 0 is an absolute no response to reflexes. 4 is a very brisk response with clonus. Clonus is rhythmic movement after the reflex has been elicited. What we want is a 2. 2s are normal. So if you look at our outcomes here for her, week 1 is when we initiated treatment. And you can see on this top row right here, C5, C6, C7, these are all upper extremity reflexes. She was hyper-reflexive, C5, C6, and then in C7, she actually had clonus. We initiated treatment, and was actually within 1 week, we returned to normal. In the lower level here, you'll see the L4, which is your kick reflex, and then S1, it's like you're driving a car, you're pushing on the pedal. You can see she was hyper-reflexive in L4. She actually got a little bit worse after the first treatment, but then rebounded back down by week 4 into a normal reflex state. And then the S1 Achilles reflex, she was actually hypo-reflexive, when within 1 treatment bumped back up to a normal level. Sorry, I'm congested today. I'm having to like breathe. Okay, so moving on. We've got the muscle grading scale. This is the strength. This is what we're looking at because she had some weakness. So just as a reminder to everybody, 0 is no contraction whatsoever. 5 is normal strength of the muscle. So we looked at her lower extremity for weakness because that was the weakest part of her body. And you can see here in dorsiflexion, knee flexion, and hip extension were the ones that were the most weak, and they were down here at a 2, a 3, and a 3. After 4 weeks of treatment, her muscle strength regained 5 out of 5 strength, and it has maintained. We follow up with her regularly, and it's continuing to be a 5 out of 5. And then we measured activities of daily living. So these are the things that you do every day. You brush your hair, you brush your teeth, you do dishes, you cook dinner. These are the things that you just do around the house all the time. So a lot of people take them, and she can't do them. So we have this Hauser's ambulation index, and we graded her on this scale throughout treatment. So 9 up here is a completely wheelchair-bound person, can't function without assistance from other people. 0 is an average person that can function by themselves, do every activity of daily living on their own. So on the first week of treatment, she was a 5, and that is needing a walker and not being able to walk 25 meters in less than 20 seconds with 2 people on either side assisting you. Throughout treatment, you can see by week 15, she dropped to a 3. A 3 is unassisted walking with a cane only as needed at 25 feet in less than 20 seconds. And actually, we've been following up with her beyond the 15 here, and she can actually drop down into the 2 category as of, last week? Last week we saw her, yeah. So she's still progressing. It's not shown on here. But this case represents a successful treatment of late-onset cerebellar ataxia with biomodulator therapy. The treatment demonstrates the ability to improve muscle strength, coordination, and improve activities of daily living better than conventional standards currently. Alrighty. Any questions? She did not. We want to get that. It is a cost for her that she can't afford right now. So yes, we would love that, but we can't get it yet. That was definitely in our differentials. We were also thinking MS, all of these along the line. But she had seen several neurologists previously, and they didn't classify anything as that yet. Yes. She was not. She didn't. She, at least that I know of, I don't know previously, but there are other doctors I'm sure that she had in the past. But since working with us, she is not. We started with weekly treatments up to about, say it was about week 6, and then the shifts went on break for 2 weeks, and she wasn't able to get back for about a month, and then after that, it was generally every 2 weeks she was able to get in. Any question?
Did she have an ataxic gait, and did that change also?
It has. We've been monitoring that as every time that she comes in, and her gait is getting more steady. Her eyes are more bright. Her speech is faster. There's multiple categories that we've been looking at. Yeah. No, we had done imaging and we had done labs and whatnot, and we couldn't find anything. And the previous neurologist that she had seen wasn't able to identify anything either. Yeah. And we would like to classify it as something further, but there's nothing to classify it with yet. 11 years, yeah. Postpartum, and then it just progressed up until we saw her. Yeah. I'm unsure. I don't, do what? Embolic phenomenon. Yeah, so she could have a stroke after giving birth. There can be all sorts of hormone-related things as well that can cause issues like that would cause ataxia. Yeah. It was on hand. Joe, Roosevelt is very much an on-hand clinic. What we have is what we use. Joe was our biomodulator guy, and we said, let's give it a shot. And then along with the supplements that we gave, we were like, let's see what happens. And then it just progressed from there. Yeah. The supplements? There were multiple that we gave, a bunch of omega-6s. We had given different, one of them was a mushroom, and then a bunch of antioxidants were the basics of the stuff that we gave. Yeah. She, at the time of initial that we had seen her, she was unable to do really anything at home. It was exhausting to her. And then as she has been getting better, she's been doing her own exercises at home. She has an exercise bike at home. She's now cleaning the house, doing all sorts of different things. So as she gets better, she's been increasing her at-home exercises.
People might not know anything about Roosevelt.
So Roosevelt Health Clinic is like the coolest place ever. So happy that you asked me. No. Roosevelt Health Clinic is in Southern Phoenix, and it is a free community clinic that SCNM runs via the Sage Foundation. And we see a ton of people, and it is an absolute great place. You get to see everybody there. They're so thankful for anything that we do. And everything is, as far as lab work is covered for them, and we can get medications at a discounted cost, not totally free. And sometimes imaging is not completely free, but we can get supplements to them really cheaply or completely free. It's really amazing. It's a great, great place. Everybody should go there and check it out. It's awesome. Yeah. We did that, I believe it was every time. Was it every time, Joe? Every time, yeah. Yep. Awesome.
Great, thank you.
Thank you.
All right, so next up, can I get a shout out for Reverend Carla Bass, who I happen to notice is here. So could you please stand up, because Reverend Bass, her company, Synergy, actually donated the machines, which we have here at the Neil Reardon Center for Regenerative Medicine. And the fact that this is available here is amazing, but also the fact that it's available at essentially a free clinic in a community that struggles to get health care altogether is really a blessing for all of us. And so thank you so much. Our next presenter is Dr. Sara Han, who is going to give a case report demonstrating the effectiveness of TCM in the management of herpetic gingiva stomatitis. Dr. Tran.
Okay. Okay, thanks for sticking around to the last talk. This talk will demonstrate the effectiveness of traditional Chinese medicine in the management of primary herpetic gingiva stomatitis. So primary, meaning that the patient has never had this diagnosis before. Herpetic, meaning it's caused by herpes simplex virus. And gingiva stomatitis, inflammation of the gums and the tongue. So as you can see here, there's quite a bit of inflammation causing bleeding in the gums, and there are some oral ulcers here. And gingiva stomatitis is the most common manifestation of HSV1. It's pretty common. Over 50% of the US population are seropositive for antibodies for HSV1, which just means you take a sample of blood, you find cellular defense mechanisms knowing that you have encountered this virus before. And roughly between 2 and 6 out of 10,000 people have been diagnosed in the ER as having this or have been admitted to the hospital for this condition. And one of the issues with it is once in contact with the skin, it'll travel up the trigeminal nerve and lie dormant in the ganglion. So once you heal from the ulcers and you're pain-free, you can have relapsing and remitting cases of this when your immune system is distracted by another illness or you have increased stress. So it can be difficult to manage. And how do you get it? You get it from direct contact, skin to skin, with an asymptomatic or symptomatic individual. You can also get it from using a towel that someone else has used with HSV, using someone else's utensils, and it's because the virus sheds. Once in contact with your skin, it'll cause tissue destruction, which will have the characteristic oral lesions that you see here. In addition, you'll have cervical lymphadenitis, so inflammation of the cervical lymph nodes, which can make it difficult to swallow, causing anorexia, difficult to drink, causing hydration issues, feelings of malaise, feeling not well, low-grade fever. And the first-line clinicians that are going to see this in clinic would be dentists or primary care physicians. And so it's important for them to understand this condition well and to diagnose it promptly so you can get the treatment. It's best to have treatment within 48 hours because once the virus starts to replicate beyond that, it's hard to control it. You'll have symptoms for a longer period of time. Standard of care, oral or topical antivirals. Typically, we use acyclovir or valcyclovir. They're the most effective. Docosahexaene, you may have seen on the shelf, it's Abreva. And in addition, you'll have supportive pain control and hydration monitoring, especially for young kiddos or severely immunocompromised individuals who might be more at risk of being nutrient deficient or dehydrated. So the case that walked into our door was a 31-year-old female. She had been diagnosed with primary herpetic gingiva stomatitis in February of this year. She had been treated by her dentist and her PCP with acyclovir, and she didn't get full resolution of symptoms. She still had cervical lymphadenopathy, a lot of ulcers in the mouth that caused pain, difficulty to eat and drink, and then she also had bleeding of the gums and swelling. So she came to us in April. She had already finished 1-week course of antivirals. Oops. And so she was seeking acupuncture. Acupuncture, as discussed before, is an ancient tradition, medical therapy. We don't really know completely how it works, but we do know that it decreases inflammation, it addresses the autonomic nervous system, and it also helps with inflammation. So those are 3 important points to hit on whenever you're dealing with this condition. So in Chinese medicine, like Dr. Felton mentioned, we use our own diagnostics in the form of looking at the patient's clinical signs and symptoms. This patient had a lot of signs of heat, and her lesions were along the stomach meridian. Her tongue was red in body, it had a white coat, and there was some mild sublingual vein distension. And feeling her pulse on either side of her wrist in 3 different locations, we noticed that there was a rapid pulse, which was over 90 beats per minute in Chinese medicine. It was also a bit wiry, felt like a tight guitar string under your fingertips, and also slippery, so like beads rolling under your fingertips. And all of this supported the diagnosis of stomach fire rising. These are the points that we used. The principle was to clear stomach fire and to stop swelling and bleeding. So from the top of the head all the way down to the toes, on either side of the arms and the legs, we put some points, about 24 points in total. And we did this once a week for 6 weeks for this patient. The herbal prescription was Coptis and Romania formula in English, 10 pills 3 times daily. And like Dr. Felton mentioned before, no bigger than the size of your pinky finger, that's the tip of it, so it's not too much of a nuisance for the patient to take 10 pills 3 times daily. So what we were tracking was % subjective improvement in her symptoms. The x-axis here is weeks, so week 1 when she was diagnosed, week 10 when she came to see us, and then the y-axis is % improvement. I don't know why it goes to 120. She was given acyclovir. She did a week's course of it, and she still maintained some of those painful symptoms, the oral ulcers, the lymphadenopathy. And then at week 10, we administered Chinese medicine in form of acupuncture and herbs. She got 100% better subjectively after the first treatment, and then she leveled out to about 90% improvement after 6 weeks. In addition, we were tracking bleeding gums and tongue, and similar improvement, a little better, but pretty marked for just one treatment, which is impressive. Swollen gums as well was very much improved. So in conclusion, antivirals and Chinese traditional medicine do not eradicate this condition, but used together, they can be very complementary and help the patient heal a little bit faster. Both their wounds and their pain can decrease. And it's safe and effective. So, any questions? Yes, Bronwyn. 7 days, I believe. Yeah. Acupuncture and the herbs, yes. That's all we did. Mm-hmm. Wonderful.
Thank you, Dr. Trahan, and all of the presenters. And before we go, I'm going to call Dr. Langland up, but could I ask all of the residents, our first year, second year, and third year residents, could you all stand up? Because not everyone got to give a case today, so including those who didn't. Dr. Salisbury. Thank you. I'm going to turn it back over to Dr. Langland to help us finish up.
So again, thank you to all the residents that we have here. One thing we always do at research nights, whether it be in the winter or in the summer presentations, we always give an award to our best presenter for the evening, and we want to recognize that person this evening. I have a couple spies in the audience who basically rank all the presentations that are being done, and tonight's best presentation goes to Dr. Milheiser. Thank you. So she gets a gift card for Amazon for $25. So thank you for attending this evening. That closes out our presentations. but look forward and plan your schedules. We'll probably have our next research night with our students doing presentations on laboratory studies around the end of February, early March of next year. Thank you very much. Have a good evening.